We spend more than anybody else on the planet on healthcare, and yet we're pretty darn mediocre.
Welcome to Longevity Roadmap. I'm Buck Joffrey, and today we have a really good show. I got a chance to talk to the American Medical Association president, Dr. Bobby Mukkamala. Dr. Mukkamala, he is, you can tell why this guy is a leader. He is a very, very smart guy, very charming. He and I talked at length about a number of topics. One of the things we talked a little bit about was his own recent brain tumor and, his experience with medicine and the system there. We talk a lot about disparity in medicine and how that disparity seems to be something that is actually growing, especially because, well, listen, we're getting, some people are getting full body MRIs because they can pay for it and some aren't, whether that's, a clinically sound thing or not aside. Okay. So we talk a lot about those types of things and then ultimately kind of finish talking about the role of influencer medicine these days. Obviously, there are a huge number of influencers out there. I guess I consider myself a bit of an influencer as well, but we're kind of focusing in on influencers who really don't come at things with any sort of scientific background or any data to back up what they're saying, which is obviously really dangerous. Anyway, really fascinating interview. Great guy. I'm glad he is the president of the AMA right now. As you'll see, I think he's got a lot of great ideas. Make sure to listen to the show, and we'll have it right after these messages.
Hey, longevity enthusiasts, it's time to take it to the next level. I've been fine-tuning my longevity regimen for years, and I look better and feel better than I did a decade ago. In fact, my blood work is even better than it was back then. And it's all because of my data-driven regimen, and it's inspired me to create a course and community just for you. It's called the Longevity Roadmap, and I urge you to check it out. If you're tired of your belly fat, tired of being tired, or just want to optimize yourself for the next 50 years, visit longevityroadmap.com. That's longevityroadmap.com.
Welcome back to Longevity Roadmap. Today, it is my pleasure to have the president of the American Medical Association, Dr. Bobby Mukkamala, on the show. He's a board-certified otolaryngologist, head and neck surgeon, and as I mentioned, the current president of the American Medical Association. He earned his medical degree and completed his residency in otolaryngology at the University of Michigan, where I spent a little bit of time in the neurosurgery department. Over 2 decades, he's served the Flint, Michigan community, not only as a surgeon, but also as a leading voice in public health and equity. Bobby, welcome to the program.
Thanks, Buck. Appreciate it. And technically, 7 years at the University of Michigan in their Inoflex program, and then 5 years at Loyola in Chicago for ENT residency.
Oh, got it.
Both of which are awesome places, great experiences. But I didn't want to leave Loyola behind.
Yeah, of course. And I was in the Chicago area. I was at Northwestern for med school, so we were very familiar with Loyola as well.
Yeah. And so I was going to say I followed you, but more like you followed me.
That's right. Well, we was pointing out online, and this is a longevity show, and I think so it makes it relevant. But I thought for sure you were younger than me looking at you, and as it turns out, you're a little bit older than me, and so you're doing something right. But
well, it's funny. I joke with people when they say that the Flint water, as bad as it was, had a little silver lining, and it's like it kept me looking younger.
Well, okay. Well, let's start with this. So I want to kind of jump into the whirlwind that was the last year for you. Obviously, becoming president of the AMA is a big deal and everything, but you had sort of a personal experience with medicine. Tell us a little bit about that and what happened and how that's changed your perspective.
Yeah, it was, looking back on it, just an amazing moment in my life. So I was elected as president of the American Medical Association June of 2024. And, you start to sort of learn about that process. You get some assignments. And then in November, just months after my election, I was giving a speech within the AMA to the minority affairs section. And as I'm giving the speech, I kind of lost track of words and, I mean, like I said, I'm older than you, so maybe I had my first brain fart. I don't know what it's called, but I was thinking, I lost my place in the on the iPad that I was using. But the audience, they'd listened to me for decades, right? They knew me for a long time since I started to get involved at the AMA. And one of them basically stood up and says, "Bobby, we don't understand you." And I apologize for missing my place on the iPad. And they're like, "No, I mean, something's wrong." And so I finished my talk. I go off to the next talk, and that one went perfect. But meanwhile, everybody is swarming in on me. And then I leave that room and they're like, "Dude, you had a stroke." And I'm like, I don't know about that. And they're like, "No, you got to go." And my wife was with them and she was like, "We got to go." And so I go to the urgent care there. They check all my vitals. Everything was fine. And then basically the recommendation was, when you get home, get an MRI scan and make sure you didn't have a stroke. Maybe it was just a TIA. And so I get home, and within a matter of hours, I get my MRI scan. And it was funny because the person that was doing it was like 9 p.m. and there was a tech there that was helping me. And the first frames basically show my nose, and I've got a wicked deviated septum. And that's what she commented on. She's like, "Man, your septum is crooked." And meanwhile, the brain is getting bigger, and this 8 centimeter tumor in my left temporal lobe. And I'm like, "Yeah, but I got
8 centimeters.
I got a big ass brain tumor, right? Forget my nose."
Oh, wow.
Yeah. So that was the diagnosis. And then it was off to the races.
Yeah. So after that, you ended up having some surgery.
Yeah. Yep. So immediately, I was on a WhatsApp call with my dad. He's a retired radiologist. And I had taken some photographs because, we don't have great interoperability of medical records yet. So here I am taking a photograph of the screen at the MRI place. And I'm talking to my dad on WhatsApp. And I said, "Hey, can you look at the scan?" And he's looking at it. He's like, "Man, this guy's got a big tumor." And I didn't say anything. And then he looked at the name to see who this guy was, and he sees my name. And totally
man.
"Let me call you back." And so he paused for a minute, called me back. Meanwhile, I'm on my way home. That scanner is like 7 minutes from home. So he's still on the WhatsApp call. When I get home, I asked my wife to come into this room. My kids are both 25. They don't live with us anymore. And so I got them on a Zoom call, got my mom on a Zoom call. And I said, "I've got a brain tumor." And people were like, "You're full of crap." And my mom was like, she's already crying. And Nita's looking at the picture up here, and my wife. And so that's when, it went from a moment of panic to within 24 hours saying, "Okay, we got to make these appointments, start making these appointments with neurosurgeons." And then I realized the access to care that I have, right? Within a matter of 48 hours, go from a symptom to an MRI scan to talking to neurosurgeons. And then within a month, going to the Mayo Clinic to Dr. Parney and having him remove it. It was the most incredible access anybody on this planet could ever have.
Right.
And yet a neighbor of mine on either side of this place that I live in, Flint, Michigan, would be waiting for weeks, if not months, for all of those things to happen. And that's when I thought, you know what? Maybe this was somebody up there that basically said, "You're about to become president of the American Medical Association in 6 months. And you've been a doctor for 25 years. You know how to talk about the healthcare aspect as a physician. But I'm going to make sure you know what it's like to be a patient navigating the system in the way that's great, to make you more aware of the things that aren't great, so you can be a better advocate." So somebody up there might have had a plan. I don't know.
Sure. And that was, and I think it was a glioma. Is that right?
Yep.
Is
Yeah.
that what you ended up
Glioma
having?
subtype. So grade 2 astrocytoma, which has, if you Google it, it says that's a 10-year average survival. But here we are with a brand new pill, and we can talk about it more if you want, but a brand new pill that was just FDA approved within months of me starting to take it. It's an IDH inhibitor, it's called, and it's meant to sort of keep this thing from growing since it has IDH receptors there. So cutting edge technology that just got approved within months of me needing it because of big time NIH funding, right? And then here we are, literally weeks after surgery, and then a potential threat to NIH funding. Again, somebody up there is like, "You know what? I'm going to let you see what it's like to have the benefit of this, and then see what it's like potentially to have it cut so you can be a better spokesperson." So amazing lining up of all these things.
Yeah, absolutely fascinating. We'll come back to that in a bit, because I think in the context of longevity stuff, it's useful to talk about. But one of the things that occurs to me too is like, so you've been in Flint the whole time, right? Is that kind of the, and so people may not know. I mean, most people probably have an idea they hear about on the news, but Flint kind of was famous for some of the problems with the water. And so can you remind people about what that was?
Yeah, yeah. In fact, at first I thought you were going to say famous for the birthplace of General Motors. Uh,
Well, well, that too.
that
But
too, that too. That was like the early chapter. That was the prequel. But on that note, this house was built by the president of General Motors
oh
in
wow, yeah.
1920. And so we went from that phase to fast forward to just, less than a decade ago, a big time problem with exposure to lead in the water that comes through I mean, I live in the city of Flint, right? So through these faucets, because there was a change in the water supply, inappropriate treatment of that change to prevent the pipes from decaying because of the stress put on them by these new chemicals, and all of a sudden we got these kids testing very high for lead in their normal sort of routine blood test. And that's when the blank hit the fan, right? I mean, my wife, even before that lead got diagnosed, she was like, "What changed with the water? It smells different." And I'm kind of a minimalist. I was like, "Yeah, whatever." I thought she's always worried too much. And she was like, "No, this smells bad." And so I smelled it. I'm like, "Yeah, this is weird." And so immediately we have the benefit, being two physicians, have the ability to get outside water in these 5-gallon containers with the dispenser in the kitchen. And we just stopped using tap water for eating and drinking. And then within months, all of a sudden we find out about the elevated lead in this water. And she was like, "I told you so. I told you so." And I was like, "Yeah, you were right." And then just seeing what people have to deal with from something that is totally preventable, but also affecting their health. So not just, their hypertension or their history of cancer, but the issues that the environment puts on their health, right? It was very eye-opening.
So I'm curious a little bit on that because, it's lead. It's, we kind of have an idea of what things that happen there. But so where I grew up, actually it was a suburb of Minneapolis, and there was like an old military. They used to have a bunch of artillery and stuff that was stored there, and then they just kind of left it and seeped it. There was whatever chemicals seeped into the ground, and the water was affected.
Mm.
And listen, I have no, direct correlation. I have no way of direct, but two of the guys that I grew up with as a little kid ended up dying of brain tumors, and it must have occurred to you at some point. I must have been thinking, like, what did I do? Where was I? Like, what kind of exposure should I have? Did any of that go in your mind?
It did. It did until I looked at the data to basically say this grade 2 astrocytoma has probably been there for years.
Yeah.
Um, I mean, I don't know that I never did the timing to see, does lead exposure cause that? If so, by now we would have had much more diagnosis of that, right? When you
Yeah,
think about all the
sure.
entire population of the city is exposed, many big time more than me, and then we're not seeing that uptick. But behavior issues, things like that, psychological, psychiatric consequences of lead exposure, that's what the data shows. But yes, that seed of thought is always in people's minds. When you have this and you have this, is it cause and effect, right? But that's where the science is so important. And that's
Yeah.
something big time that the American Medical Association is saying, you know what, follow the science before making a conclusion, as opposed to follow the very charismatic social personality that says something and take that as data and science, right? That's the
Yeah.
big difference.
Yeah, for sure. Okay, well, so as as the president of the AMA, how do you view the organization's role in shaping the conversation around a lot of this emerging longevity medicine, health span, preventative health optimization, which really has sort of gone in overdrive in I'd say the last 5 to 10 years.
Yep.
It's a slippery slope, but I'm curious how the AMA is looking at it.
Yeah. I mean, I think that, traditionally physicians are where you go if you're having chest pain, if you got, some expressive aphasia, turns out to be a brain tumor. So in the acute phase of things is traditionally what people look at physicians to do. But I think there's a critical role in prevention as well, right? And I think that's what's most important for the future of healthcare in this country. We'll obviously still continue to take care of people when they have an issue, right? And that's what hospitals are for.
Right.
But I would love to see the focus of healthcare add, not subtract from here, because this is always going to be necessary, but add to the prevention of disease, right? Whether that's access to healthy food, whether that's access to a good place to exercise, whether that's, looking at and evaluating people that have an issue and saying, what, good hours of sleep. These are all things that, this is what lifestyle medicine covers. And that's something that's big time sort of getting more and more popular. I think we have 11,000 people now that have, 11,000 members now that have taken their board exam. It's a couple thousand a year. And I think that's a wonderful place to focus in addition to the acute onset of medicine. And personally, this is a total prediction, not science, but sort of my optimism, perhaps my hope, is that the more we invest and do this, the prevention of disease, the less we will need of this. Maybe in a generation, hopefully maybe even half a generation, not this year to next year, not this decade to next decade, but I would love to see us focus more on this to make this less and less necessary.
Yeah. Part of the, I think in my view, just from the perspective of somebody sort of, hitting this longevity space hard, is that it's hard to get some physicians to change gears, right? Yep. For the most part, physicians are trained to be pretty reactive still, and to generally look at, even if you're looking at, somebody's lipid profile or something, to let somebody's, cholesterol ride a little high because, it's not terrible, you're a young person, whatever. How do you get a generation of physicians to start thinking differently about how to approach this and not be so reactive and start projecting out, not 5 years, but 20 years in somebody's life to prevent some of these issues?
Yeah, I mean, I think that's a critical goal because that improves humanity, right? And that should be the goal, not deal with humanity when the blank hits the fan, right? And so, I live in Flint, Michigan. I-75 is a big expressway that goes right, right on the other side of that wall over there. There's a GM plant, and then right in between is I-69 meeting I-75. The reason I mention it is that every billboard I see that's sort of hospital-oriented or healthcare-oriented is about the hernia, the hip replacement, this symptom, that symptom. I mean, I'm seeing a freaking hernia billboard, but nothing about good nutrition, good sleep, things to prevent disease, right? And so the metrics, the finances, all those things about healthcare in this country are focused on just this. Not that it's not important, but I think that to get back to this direction, not even back, I don't know that we've ever been there, but having the physician role be just as much on prevention of disease instead of just saying, yep, that's a hernia, this is when I'm going to schedule it to be fixed, is going to be a wonderful evolution of healthcare. And I think that's a passion of mine, and it's also very important to the American Medical Association, right?
How do you change people's minds, or how do you change the way they practice, though? I mean, I think that's kind of what my frustration is I still, listen, I don't expect everybody to completely adopt the way I view medicine, which is probably a little, not within the mainstream. It's probably a little bit, more aggressive, but they could have a little bit more.
Yep. So, I mean, I guess I think about it like this, right? We look at what a neurosurgeon or an otolaryngologist gets compensated for the care they give to their patients. And then we look at what a pediatrician is compensated for caring for their patients. Both are critically important, right? We want kids to have the conversation about, this is what you should be doing, this is how many calories, this is what you should eat, this is what you should not eat. An amazingly useful conversation that changes the way this kid looks at things now and as they grow, right? And yet you look at what the system values this at versus this, and there's a huge difference, right? And we see medical students that, the medical students that might come from Flint, Michigan, that say, I want to go back to Flint. I want to take care of these people. I want to take care of these kids. I want to go into primary care. And their debt is more than $250,000 or $300,000 if they go to a private school that's now being cut, by a new government proposal to say, you're going to be capped at 200. Where are people from Flint, Michigan to come up with an extra 100, 150 grand from a bank? And this may be a poor kid from Flint that wants to be a pediatrician in his community. All of a sudden the math doesn't support it. And they're like, what? That Dr. Mukkamala lives across the street. That's a pretty nice house. He doesn't have any debt anymore. I'm going to become an otolaryngologist. Well, that's like, oh crap. You know what I mean? And
so you got to change the reimbursement. You have to make reimbursement more, incentivize people to practice a certain way.
Yeah, I
right?
mean, when I think about if I was the CEO of an insurance company and I was thinking about the future of making people healthier, then I would say, okay, what does it take to make people healthier? What do we do now? And it's exactly those conversations that you're referring to about this is, and again, all those principles we talked about what you eat, how you exercise, what to screen for, how to deal with things, not just by getting a prescription, but instead looking at the lifestyle that might prevent this disease. And as an insurance company, you're like, you know what? Yeah, that's a good investment. Maybe the people that do that in their offices, it's not brain surgery, it's not a laryngectomy, right? But
Right.
yet it should be valued higher than it is. And that's not where we are, but where I would love to see us go.
How do you attack that as somebody in in your position? How do you start to address some of these things with insurance companies?
Yeah, yeah. I mean, so there's a process of giving value to what a physician does. That's the relative value unit. That's something that the AMA facilitates and gets a lot of people to come in and talk about. These are the metrics of this versus this. And much of that has to do with the technical aspect. How long does it take? What's the risk? What's the risk of something going wrong and being a malpractice risk? These are the basic factors. None of them have to do with society and the direction we want to go as society, but it's not excluded from that, right? So we give this as advice to the people that decide, okay, this is what this aneurysm compensates, and this is what preventing of the aneurysm compensates. And they can say, you know what, let's focus more on prevention. Yes, this is what the RVU says about risk and malpractice and all that stuff. But as a society, we want to prevent that. So we are going to add value to prevention in addition to the basics of it, the detailed numbers. The philosophical goal should be value, right? And that's what we're hoping happens. So that in primary care, there's not this gap. This is valued just as much.
Right, right. There is sort of the next level on this stuff where, again, sort of the longevity community is like take something like full body imaging, right? Like in your situation, for example, if you had a full body MRI, you might have caught this glioma at 1 centimeter, and would that have made a difference in your outcome? Maybe, but there's a lot of things out there about that are sort of in the pipeline in terms of early discovery that are really they're not really within the realm of daily 9 to 5 internal medicine. And do you see those things starting to infiltrate into the mainstream process? And I guess what's the AMA's position on this? Are we starting to look at some of these things and say, hey, maybe we ought to start recommending this? Or I'm trying to think about some of the benefits that are coming to mainstream medicine from quirky folks like us.
Yeah, I mean, there's certainly those possibilities for sure, right? You tell the story just like you did about, this guy got an MRI scan, but if he would have gotten it 6 years earlier, would have been not 8 centimeters, which is what mine was, but maybe 8 millimeters.
Yeah.
Right? And so all of a sudden, the risk of surgery, the risk of this coming back might change. But the question is, does the science support that? Right. And
Yeah.
so there's always going to be individual stories that, yep, that's justified. And then there's other ones where I got an MRI scan, it showed this thing, and they thought it was this. It was this, and so it became 6 more months of workup and a needle biopsy, and it turns out it was just this, right? And so I see people all the time. I mean, I'm an otolaryngologist, right? And so
Sure.
you know exactly what that's like. I see people with a cyst in their maxillary sinuses 5 times a day, right? And so getting the test generates several more appointments. And we know as otolaryngologists that, you know what, that if I scan 100 people driving down the road over there, 25, 30 of them are going to have something like that. If I was operating on everybody that had a cyst, I'd be working 24/7, 365.
Yeah.
You know what I
Sure.
mean?
Sure.
And so just because we can doesn't mean we should. The data should tell us when the things we find are important to do something about. And based on that, how many people are going to show something that they need something done, and how many people are going to show something that we don't need to do anything, but now it's creating all this. I mean, sometimes it's harmful, right? You do a biopsy on something that doesn't need a biopsy. So most of the time things go okay, but many times they don't, right? And then there's the cost of healthcare in this country. we spend more than anybody else on the planet on healthcare. And yet we're pretty darn mediocre, right? So I represent the American Medical Association in the United States at the World Medical Association, right? So we go there, and I do some research. I just want to know what things are like for us versus other people. And I see that in developed countries, the things like management of disease, prevention of disease, screening for stuff, we are average at best, oftentimes number 13 out of 13. And so I think about what is it that leads to that? And it brings me to this point, which is that I think we should focus on disease prevention and make that investment so that we raise from number 13 to, geez, if in my lifetime we got to the halfway point of that list, I'd be a happy guy.
Yeah. Is there, one of the things that I've noticed is that really when it comes to a lot of the longevity stuff that we're talking about, whether it's full body MRIs or stuff like that, these things, it almost doesn't really matter if they become accepted by mainstream medicine or not. There seems to be sort of this bifurcation of, people with money going in a different direction and saying, you know what, I want my full body MRI. I want my liquid biopsy. I want this. How does that change medicine in general? What's the impact of that?
Yeah. I mean, I think assuming that what they're doing improves their health, right? Because again, that's a little bit of an assumption.
No, again.
How many people are going to get a pneumothorax from getting something done that they didn't need because the scan showed this? So assuming that they're detecting things earlier and they're increasing their health by doing it, it adds to the disparity of healthcare. Because you're right, an insurance company that can't pull up an article or several articles that justify doing something aren't going to cover it, right? At best, we'll have a bunch of prior authorization required, which is another sort of pain in the neck that we can talk about. But at worst, they're not going to cover it. And that's going to leave people that could benefit from it, but can't afford the $1,000 test, which is pretty much 50% of the city that I live in, aren't going to get the benefit, right? And so that adds to healthcare disparities. And that's a huge focus of the American Medical Association and me personally, based on what I benefited from and what my neighbors wouldn't, to work on closing that gap. And I would say that going down that road where if you have money, you can get this, and if you don't get to extend your life, that's widening that gap.
Yeah. Let's take a moment just to kind of revisit the drug that you were taking. We talked a little, a fair amount of sort of basic science here. What's the advancement there for gliomas? I mean, this is it's not a glioblastoma multiforme. It's a low grade glioma, but it's still something we haven't had a whole lot historically to do much with. So what is this new medication?
Yeah, it's called an IDH inhibitor. So IDH is it's a chemical that should stay in a certain state, but then because of a mutation, it continues to change and then it turns into something that grows. And so this basically inhibits the conversion of a normal chemical to an abnormal chemical that then leads to growth of the brain cells. And so this is something that could leave or perhaps even shrink. There's some studies that shows that because they got 90% of my tumor out. The rest of it was very medial, and they're like, you know what, this is going to be too high risk. I wanted to survive. I wanted to go home, and not have a stroke or something like that, or not make it off the table, which itself was like 1% risk. Which 1 out of 100, that's a whole lot of people in this town, let alone this country, right? So anyway, this is something that is now available for this last 10% to keep it from growing and maybe even shrink it. And so it is amazing discovery because of the science that goes in. But the thing that just boggles my mind, this pill, I ask people to guess how much it costs, but I will spare you that. $250,000 a year.
Wow.
Yeah. And so I take every night at 9 p.m. my alarm goes off and I take this pill. And that I can kind of understand why there's prior authorization for that, right? Because the insurance company covering it, which they do, they want to make sure that, it's something that is justified by the science. But a little tangential thing, if I was a diabetic on insulin, $60 a month, $90 a month. It's been around forever. Every 90 days, I got to get my prior authorization filled to get my insulin, right? So this one, I understand, $250,000. Come on, $60 a month? No way.
Yeah.
So anyway, these are the things that are on my mind when I take this pill. It's funny. I'll tell you a funny story. This is a pill that at this price, $900 a day, if it falls on the floor, I'm going to pick it up. I'm going to brush it off. I'm going to take that pill. You know what I mean? If it was a Tylenol, I'd be like, yeah, I got another 200 in that thing. I'm going to take that. But yeah, this one, if I drop, I rinse it off and I take it.
Yeah. What's interesting is we live in sort of this this period of time with sort of real advances in science and medicine and artificial intelligence. That's also got to be something that you're thinking to yourself ahead of time. I mean, to your point about not trying to get all the tumor and risk other things. I mean, if we're starting to find some medications that might slow this thing down, and gosh, what happens the next decade? I mean, you have lots of other opportunities potentially to slow this thing down, right?
Yeah. Oh yeah, for sure. And you mentioned artificial intelligence. I mean, this is very much a focus of the American Medical Association. Just like, you think about organizations in our country, and like, for example, the Substance Use and Pain Care Task Force that I chair at the American Medical Association, we're always thinking about not what's going on today, but what's coming tomorrow, what's coming 6 months from now, what's coming a year from now that we need to be aware of so that we're not chasing it from behind, right? So what drug is it that's going to cause a problem for the substance use disorder people? So in the same way, artificial intelligence, which we refer to as augmented intelligence, the American Medical Association, AI stands for augmented intelligence. It needs to augment my ability to take care of patients as opposed to substituting it for something artificial. And so that is cutting edge. And it's something that so many physicians are super excited about, but super scared about. You know what I mean? Because there's things like, if this thing isn't perfect and it makes a mistake on a patient that has some consequence, right? Whether that's mild, whether that's severe, but something that takes healthcare of this patient in the wrong direction because augmented intelligence was used, who's responsible for that, right? Is it me? That, sometimes we're not even aware that there's AI involved in what we're doing, because let's say a hospital invests in some program that basically double checks this or says that, that's AI based, and I might not even know it. And yet here it is on my computer and it has a bad outcome. Is it me that should be responsible, not even knowing that that's the issue? Is it the hospital that should be responsible? Is it the developer of that augmented intelligence program that should be? So these are the details that somewhat make the physicians nervous, at the same time excited, right? One of the things I use in my speech is, we have a summer home that's on a lake, and that lake is something that, a lot of people swim in it. If I see a patient on a Friday, last patient of the day, I'm ready for the weekend, and this patient has otitis externa, and I'm thinking, okay, well, you know what, neomycin, that's what we usually use, 3 drops 3 times a day, 2 weeks, call me if you have a problem, and then I'm heading out the door. If I have AI on my computer, right, that augments my intelligence, it says, you know what, this guy lives on this lake, this patient, and just earlier today, the news put out an E. coli breakout on that lake. Therefore, you should use Cipro instead of neomycin because the response of E. coli to Cipro is a little higher. You should consider changing that. That is an amazing application of something that augments my intelligence.
Yeah.
And so that's the reason I'm excited about it. So you got both of these emotions going on in physicians' minds, and we want to be involved, right? So when it comes out, we want to help create it and assess it.
What creates the clunkiness of modern medicine, though? I mean, there's a because you talk about that, and believe me, I'm all for it, right? I love the idea of putting technology and things into it, but when I go in, I still go in as a patient, I'm still like, are you kidding me?
Oh yeah, yep. So
you saw the glitches involved and all that,
The most exemplary thing of that thought, I think, is the fact that, so my wife's an OBGYN, Nita. That's her desk back there.
Uh-huh.
She does robotic surgery, robotic hysterectomy, right?
Yeah.
Cutting edge stuff, amazing, on one of those Da Vinci machines or something like that.
Yeah.
And so cutting edge. She comes back to the office, wants to let the primary care physician know how things went, when that sort of thing, and takes the op note and faxes it to the primary care physician. Literally. You know what I mean?
Right. Facts.
That
right.
is
I love it.
ridiculous.
Yeah.
The fact that she's doing robotic surgery and using a fax machine. I went to the Consumer Electronics Show in Vegas a couple of years ago.
Yeah.
And I told him the story. Robotic surgery and a fax machine. Half of the audience thought I was joking. Like, what do you mean you still got a fax machine? We haven't had one in almost a decade or so. And I was like, oh no, we got a fax machine, right? And now we do digital faxes, but it's still a totally, not a digital product, right? This is something where you gotta be able to read this stuff as opposed to scanning and having it pop up on your EHR electronically. And so this is the kind of thing that it causes so much frustration when we think about what we're capable of. Those things that generate revenue, right? You do this amazing tech. There's profitability in it for the person that makes the instrument, that makes the drug, but yet we are still using fax machines because of a lack of forcing the people that are involved in creating those products to talk together, right? I think the other example I give is if you've got a Sprint phone and I've got a Verizon phone, I can still call you. You know what I mean? Your phone rings.
Yeah.
Two different manufacturers, but they have to use the same system to communicate, but not as it relates to health.
Is that something at the level of I don't even know what causes that though. I mean, why in medicine of all things is that a problem as opposed not in the rest of the world?
So I think that it was one of those things that, when we look at AI, it's the same sort of example I'm about to give. There are some countries that say we really need to be on the cutting edge of technology, right? We need to definitely be the first country to be able to electronically exchange information instead of using paper charts so it can easily go from one place to the other. The other opinion on exactly that choice is, yeah, this is fantastic, but we need to have regulations so it does what we want it to do and follows the rules. Just like they say to Flint, to Verizon and Sprint, that you guys can both do cell phones, but they got to talk, right? So cutting edge versus restrictions about how you do that cutting edge. And I think this is something we see from one side of the Atlantic to the other, right? We can be cutting edge with AI in this country. And in Europe, I think that they are a little bit more cautious about if you're going to do it, this is what it's got to do. And that's this balance that has to happen. And so I think that's has a lot to do with it. When you don't have at least a little bit of balance to say, yeah, fine, you can definitely do EHRs, but you got to be able to talk the same language. You can definitely do AI, but it needs to do this, this, and this for safety reasons.
Sure. The last thing I really want to, I would love to get your commentary on is there's this, there's this entire thing that didn't exist 20 years ago, which is this influencer medicine. And it's something that I feel like I'm kind of battling against as well, because, what I'm trying to do is tell people about what the real findings are, what the real exciting things are in longevity. But it seems to me that there is some of these influencers so powerful, and they are fundamentally sort of changing the way, people behave. A lot of conspiracy type things, a lot of, I've never heard, so many people have an opinion on lipids and, not needing to control their LDL cholesterol or ApoB or whatever. I gotta imagine that from the AMA's perspective, that you're looking at this saying, how do we change this? I mean, how do we redirect the conversation, the lack of trust in conventional medicine by a growing part of the population?
Yeah. I mean, I think it's a critical activity that needs to be done by the American Medical Association and others to keep the country going in the right direction as medicine evolves, like it did for this thing.
Sure.
Versus going in the wrong direction for what evolves. You know what I mean? And so there should be consequences to those people that are pushing something that isn't based on science, right? Whether that's, the licensure, their ability to practice, that sort of thing. So that's part of the approach to how you deal with that. But the more subtle approach, when it's not an obvious big time failure / mistake that's going to hurt people, if it's more a difference of opinion, one that's based on science and one that's not based on science, what I see, and this is sort of right to what you're saying, this person that's based on science could be a Nobel Prize winning genius as far as it comes to the output of their work. But they could be the most boring personality
That's
that
right.
people couldn't even listen to for 60 seconds before starting snoring.
Mm-hmm.
And then you got this other person who's Oscar winning sort of personality and facial expression and the things that they do to just create a passion in the listener. Like, oh my God, this guy's amazing. And yet the stuff they say has no justification in the science. And this is what we're dealing with. You know what I mean? And I think
and in fact, I'll tell you, Bobby,
Yeah.
one of the, I won't mention a name, but one of the biggest non-physician influencers out there is a guy who I know because, so I'm an entrepreneur as well. And
Mhm.
I knew him from a group of marketers, that's sort of most elite marketers in the world. And everybody kind of recognized him as the best marketer in the world.
Yeah.
And he is absolutely in the lead of the non-physician influencers, and the stuff that comes out of his mouth. Oh my gosh. I'm just like, how do you, and huge followings, how do you possibly go against that? Like, how do you defend against that?
It can't be from a totally science-based, accurate white paper. You know what I mean? It just can't be
Yeah.
that. I mean,
Yeah.
it's
You're
like
going to lose.
David versus Goliath. You know what I mean?
Right.
It's pretty guaranteed
Right.
what's going to happen. And so, fortunately, I think it's going to come from the social media output of the things that are factual, that are based on data, based on science, that will counter those opinions, right? And that's going to be personalities like yours. You know what I mean?
Yeah.
And it's a heavy thing for you to be responsible for, but it takes more than one. But this is, I think, where we have to go in improving the health of our country, decreasing the risk of our country, going in the right direction, needs to come from a Goliath versus Goliath thing. Although David
Yeah.
won, so David versus David.
Yeah.
I think that's what it has to be.
Yeah. And so, you've got to recruit people. You've got to
Oh, yeah.
get
people
on board to start that battle. I couldn't agree more. I think that's the way you do it.
Yeah.
You
But I think that, one more thing is that, the American Medical Association works a lot with medical students, right? I mean,
yeah.
they totally contribute to everything we do, some amazing things. And this is an opportunity to, instead of getting somebody that's 54, yeah, I'm 54, like me, to say, you know what, you need to change the way you talk about what we know to be true about preventing throat cancer.
Yeah.
And if I don't have that personality, if I didn't train to be the public voice as opposed to the voice in my exam room in my office, it's a big ask. But medical students, right? They're a wonderful group to be able to make that part of the teaching, right? So the AMA puts out something called health system science, right? Not just the biology and the histology and the pathology, but this is how the health system works. And one of those chapters could be the consequence of misinformation is bad for the community. This is how you are the answer for how that negatively affects so you can positively affect. And medical students, I think, would really enjoy having that be part of their curriculum. That'd be freaking awesome.
Yeah. A little social media class.
Yeah, right.
Right.
Yeah.
Well, thank you. Thank you so much for being on the show today. I know you're a busy guy. You've got a lot of things going on. And good luck with the tumor. It sounds like you're in good shape there, but it's been
this is what I call my bonus years, right? I mean, I got 10 years or 20 years. It's amazing how happy I am having gone through what I went through less than a year ago about what the future holds. And being in bonus years is fantastic. So thank you.
Yeah, thank you.
Thanks for listening. A quick reminder that while I am, in fact, a surgeon, nothing I say should be construed as medical advice. Now, make sure to include your physician in any medical decisions you make. And also, if you're enjoying the show, please make sure to show your support with a like, share, or subscribe.